So I would just like to say thank you for coming this morning to Breakfast with the Chiefs. This will be our last session for the summer, so we'll be taking July and August off. And for that, I actually wanted to take a minute just to thank our sponsors. Without the support of our sponsors, we wouldn't be able to have these events. They are what make it possible for us. So the Canadian Foundation for Healthcare Improvement is supporting this morning. Medtronic, I think I saw Neil, I'm not sure if I saw him, Neil Fraser, Narvari, John Sinclair is here, NRC, Sonia Jacobs, and Ron Carklin, I think they're here, and Telus, Alina, are you here? And last is also Mount Sinai Health System for making this facility available for us this morning. So, I like to keep my speaking notes extremely short, and that will be that. Without any further delay, Ed Brown.
Great. Thanks for the quick intro there, Matt, and thanks for having me, and good morning, everybody. Great to see you here. I know this is a very interesting time in Ontario, so thank you for taking a day off the campaign trail. I know you were all out campaigning. Actually, this is a very interesting time. I think tomorrow might mark the end of some kind of an era. And if anybody knows what's going to happen to healthcare starting on Friday, please let me know after the presentation, because I don't really have any clues. Anybody know what the platforms are? I don't. Somebody does? Who? Who said that? We're going to get you to come up and talk here. I'll leave you a few minutes at the end. But what I wanted to do was maybe, I don't know, be a little different today. I want to try some new things I've never tried before. I'm really interested in what you think about it. You're kind of an experimental audience for this. But I know that you're all going to keep this a secret, right? It's just between us? Okay, that's great. What I want to talk about today is really three ideas that I think can disrupt the healthcare system. Leveraging virtual healthcare, which is what we do at OTN. I want to present some of these ideas, really some idea of how we can collectively actually make them happen, and just maybe inject a couple of new ideas into our conversation about where healthcare should go. But before I actually do any of that, this is a disclaimer. OTN is a not-for-profit organization funded by the Ministry of Health. So we don't speak for the Ministry of Health. That's probably a good thing today because, as I said, I want to be kind of brutally honest and tell you my personal feelings. So this may not represent the feelings of OTN. By the way, my board chair, is she here somewhere? Is over there? Yeah. Might get fired today, right? Marcia? Yeah. Okay. You can fire me at the end of the talk. Okay? Yeah, thanks. Okay, so just in case you don't know what virtual care is, some of you might be newbies. Probably everybody knows what this is. Electronic health records. There's somebody here from eHealth Ontario. You know what this is. We've been spending a lot of years developing the data, the information, physician records, hospital records, data sharing. What we do is a little different. It's called virtual healthcare, and this is a very complicated diagram. Kind of looks like that. Okay, so there's an overlap because we use data, but virtual healthcare is about the actual delivery of care. It's how we deliver care to patients. And what we want to do is create a system that has better delivery, faster, cheaper, better for patients. That's really what we're trying to do in the virtual care space. So just a bit about OTN. As I said, we're not for profit. We're funded by the government. We have an enormous membership. We have pretty much every hospital in the province. We have about 400 mental health agencies, every prison, public health, Aboriginal partners, about 120 Aboriginal communities across the province, most family health teams. So you get the idea. This is a pretty extensive network, and in fact, it's probably the largest collection of organizations and probably largest geography of a network that you'll find. And there's a lot of people using it. So there's over 28,000 providers that are on our hub, and that includes over 10,000 physicians who are using our online services. So that's who we are. What I actually want to talk about today is this. So these are the three ideas that I think can help disrupt healthcare. One is about how we take access from where it is today to the next level. The second one is using that power of self-management, which I'll go into some detail around. And the idea of how do we actually create a patient-centered system? We call a lot of things patient-centered with a capital P, but when it comes down to it, how many of them really are centered on the patient? And how can we use modern technology to actually create that patient-centered system we all care about? So what I'm going to do is I'm going to give you some examples, some stuff that OTN is doing to show you that this is real, and a little bit about where I think it can go in each of these three areas. But I guess the first question, though, is like, why do we have to disrupt? And what does disruption mean? Well, I guess, let me do a little survey here. Who thinks the healthcare system is running super well? Anybody? Put up your hand. Anybody think it's not running super well? Couple? Okay. Anybody sitting on the fence? Fence sitter? Oh, one fence sitter. Okay. You're making it better there, so you get to sit in the fence. So I think we have a challenge, obviously, and don't take my word for it. Don't take your word for it. Let's see what these surveys show. So you've probably heard of the Commonwealth study. They look at all the OECD nations. So look at this one. Same-day appointments, very difficult to get in Canada. These are all the major OECD countries. I don't know if you can read the names, but we happen to be at the bottom, right? Getting a same-day or next-day appointment, we are the worst in the OECD countries. What about wait times for specialists? Uh-oh, we're the worst. Okay, I hope that's not a shock to you. We're the worst of all of those countries. The good news is we actually like our physicians. That's great. But we also don't really think the system works so well. We're not last, though. We're third from last in how we rate our system. And then this one is probably the most telling. Only 35% of Canadians think that the system works pretty well and just needs some minor changes. So fully 65%, two-thirds of us believe that there are serious changes to our system that are required. Those 35% there that think it's pretty good, they don't use healthcare. They're healthy. Just a guess, just a guess. Okay, so here's the second reason we need to disrupt this is that we have, a very different set of requirements now for healthcare. We created 1960s Medicare because we didn't want people to go broke seeing the doctor or going to the hospital. And that was amazing, right? You don't end up, in financial ruin when you get sick. In those days, you went to see the doctor, you went to the hospital, either you survived or you didn't, right? And that was the end of your care for the most part. But we're way better now. So we have people living with all kinds of chronic disease. We have aging populations in the community. And what we have to do is create a system that keeps people happy and healthy in their homes. And we don't have that system yet. So we need to do something about that. And finally, we need to disrupt because we can. Every other industry has just used technology in amazing ways. They've revolutionized the way you shop, the way you travel, the way you watch your entertainment. And we're starting to see that in healthcare, but we haven't got to where we want to be yet. And the promise is amazing. In the work that we've done and that we've seen around the world, these solutions, they improve access, they create a much better patient experience. And the amazing thing is they're also normally more efficient at a system level. So it's a total win-win. Better care, better patient experience, and if we organize ourselves properly, it should be cheaper to do as well, or at least equally as expensive. So that's kind of where we are with disruption. So what I want to do is start with number one here and just tell you a bit about access. Just so you know, we have a very long history of doing this in Ontario. That's kind of why OTN has been around. We've been here for over a decade. And that history really starts here. So, get on the plane out here, fly north. This is what you see. If you could see out the window here, you would see probably a third of Ontario's population. You could probably find out the window here. But this is a very, very big province, right? This province is bigger than, Germany plus France. And there's lots of people living in smaller communities that don't have the same access as you do here at Mount Sinai Hospital. In fact, most of our province happens to be rocks and lakes and trees, just like this. And so that was the driver to get us started. And we started doing stuff like this, clinical video conferencing. So this is a specialist at one of our hospitals here. That's a patient 1,000 kilometers away in Upper Rubber Boot, Ontario. They can see each other, talk to each other. They can deliver care just like this. So we have a very active service here in Ontario. Last year there were almost 900,000 patient events doing this kind of thing. We avoided 270 million kilometers of travel, enough travel to go to the moon and back. How many times do you think? Anybody have a guess? Matt, moon and back? 340 times, but you were close. He's a very smart man, Matt. We avoid a lot of carbon pollution, and we're saving the government, avoiding costs for government in the range of about $40 million, $50 million per year in Northern Health Travel Grants. So this is a very successful service. Of course, that was a hardware type unit. This is now all software. 3 or 4 years ago, using your own device, your iPad, your computer, eclipsed the use of those hardware systems. And that, of course, allows us to move into the home. Here's another well-kept secret. 118,000 home visits last year, right? Direct into homes using this technology. And our government gave us the go-ahead to pay specialists for home visits, follow-up visits, for example, for patients. And we've got about 500 new specialists who are now doing this into the home, normally for your follow-up visit. I just want to show you what this all means for patients, particularly rural patients. I mean, this is now happening in the city as well, as you can imagine. But here's a little kind of ad we put together that will just give you a quick snapshot of what this really means for people.
Time for your breathing treatment. Okay. Press button.
Good morning.
Good morning, Dr. Gill.
How have you been feeling the past few weeks, Sam?
Good?
Any coughing or wheezing, Mom?
Not since we spoke 2 weeks ago.
Must be all that clean air up there. It's good to see that the puffers are working. Mom, has he been staying active?
So active, we can't keep him in the house.
The message here is for the average patient in a rural area, the average travel time is 4 hours for medical care. The average appointment is 10 minutes long. Okay? So if you can do this from your home, and this little kid right here is doing it from his home, that is keeping them, saving a lot of energy and time. So very convenient for them, much better access. I wanted to give you a local example. We're in Mount Sinai Hospital, and this is a program that they pioneered. Pregnant people are usually very happy about being pregnant, but as it turns out, about 15% have serious mental health issues during that perinatal period, and there's mental health professionals that work with them. The problem is these patients need to come down to Mount Sinai to get their counseling, and they often live all over the city, and guess what? They often have other little kids at home. So it's hard to get here. So this is actually a real patient. She's sitting in her living room. They're now getting access directly from home to those specialists, and they love the program. So it's dead simple. There's not rocket science here, but being able to introduce this kind of technology out into the community is incredible for patients, an incredible advantage for them. There's also lots of fun things that happen out there. So we happen to have all the prisons in Ontario wired up now. Last year, they actually saved $5 million by avoiding transferring patients back and forth. They had to pay for armed guards. They had to pay overtime to police officers to sit with them in hospitals and offices. So they actually avoided $5 million by using telemedicine. The lady that we worked with at Corrections that did this, she got the Premier's Medal for this. She got a promotion. We got a pat in the back. It was lovely. And there's lots of exciting stuff like this you don't hear about. There's very large virtual ICU programs across the province. Orange, the Air Ambulance Group, is delivering emergency care to remote First Nations communities. There's a 24/7 emergency telestroke network, so there's lots of exciting programs once you have this technology in place. This is a little different. E-consult program is now a provincial program in Ontario. This actually allows primary care docs to ask a question to specialists and get an answer back. And that means the patient doesn't always have to see the specialist. It also means that we're reducing the wait times for the patient from an average of 53 days in Ontario to roughly 2 days, right? A little better than we have in the past. Maybe we'll have a better OECD survey next time around. And this is pretty popular. There's almost 8,000 primary care providers who are referring patients. And finally, this is the bold new frontier. So as a patient, what I really want is access to healthcare when I want it, on my terms, from my home. Okay, so this is a program where patients can access their own primary care providers. They can start by sending a secure message, asking a question. Often, about 75% of the time, the physicians can solve that with secure messages back. About 25% of the time, they're escalating to video. It's patient-centered. We've rolled this out with 2 LHINs, Central West and Waterloo Wellington. We've got 2 great vendors. One of them's a sponsor here that are actually providing this. So you've probably heard about a lot of the private companies that are starting to do this. And they're doing a good job. However, they're charging patients. And what we want to do is make this part of the health system. And ideally, we'd like it to be your primary care provider practice that provides this service to you. So that's what we're trying to do. It's slower than we'd like it to be. It's probably shocking to you to realize that physicians are much more focused on their clinical acumen than on customer service. Is that a surprise? Yeah. In fact, when you're sitting in their waiting room, you have a lot more time to study customer service than they do because they're busy. So you wait, and this is very customer focused, and they like it, they're into it, but they're doing it slowly, cautiously, and some of them, of course, are lagging at it. But I'm very excited to say that we've got a number of new LHINs that are going to be starting this year. The next one will be Central East in the next little while. We're hoping the rest will convert and sign up and start to organize this as well. And of course, the key to this is that the province is allowing us to pilot a fee schedule so we can actually pay physicians for doing this activity, which is great. By the way, if you look at other places, Kaiser Permanente is the example everybody pulls out of their hat. 52% of their primary care interactions between patients and providers are now done this way. So this is not a little thing on the side. This is actually how healthcare is going to be delivered. The part where you go to the office is going to become increasingly rare. So think about that for a minute. And finally, where might this go? This is a mock-up. This is not real, but this is happening in some jurisdictions. So imagine we have a place where people in Ontario can go. We've called it Care Now Ontario. That is not a real nurse. That is a robot. Okay, she's a bot. And those bots are out there. It's AI, where you can enter your symptoms. It'll ask you questions. It'll help you come to some way of managing your condition. Of course, if you don't like the advice or they can't solve it, then you go down to the bottom right corner there, and you can call Telehealth Ontario and talk to a nurse, or you can use that e-visit solution that I showed you a little earlier, where you could actually ask a primary care doc a question and hopefully get an answer. So imagine how great this would be in the middle of the night when you have those questions, instead of going to Emerge, being able to get some diagnosis. And of course, we need to make these helplines more visible. We have crisis lines, we have gambling addiction lines. And so how do we make sure people can find the stuff? And how can they find programs that might be helpful for them? So we need a place where people can go and get this kind of care, which we don't quite have yet. If you clicked on a program there, you should be able to see what's in your neighborhood and look at diseases, look at your area code, and just see what's available for you. So that's kind of that idea. Finally, this is becoming pretty standard out there. This one's happened to be called Tyto. It's a device in your home that'll check your heart, check your lungs, breath sounds. You can look in the ears, the skin, look down the throat, get a temperature, even listen to abdominal sounds, all with that one little device. Costs $299 US at the moment. These will get cheaper. But imagine if you have this in your home combined with that e-visit. I don't know if you've ever had a kid with a fever at 2 in the morning. Wow, wouldn't it be great to be able to stick that thing in the ear instead of going to the Emerge, have a truck with some Amoxil pull up to your door. so that you don't have to spend hours and nights in the emerge. This would be phenomenal. And this is all existing FDA-approved technology now in the US. So here's the bottom line. I think we're just starting. I think, we've been growing these services, in terms of access, but I think there's incredible untapped potential to move this forward. Number two here, this is the second disruptive idea. This actually has been a personal journey for me. So I'm kind of a hardcore science-based physician by background. I did emergency medicine for about 15 years and some family practice. I have, I think, now become a radical patient advocate. I don't know if you've heard that in my voice here. And part of that is because I have seen what you can do when you do things like this. And I'll give you some examples here, but I think the bottom line is, I mentioned we have a different healthcare system. Chronic disease is now the biggest challenge that we have. And the good news is people are living a lot longer. The bad news is people are living a lot longer, okay? But they're living with serious health issues, decreased quality of life, and they're in and out of the hospital a lot. The reality is we can actually help them stay healthy and out of the hospital. And that requires self-management. It requires help complying with their regimens. It requires understanding the triggers that cause them to get sick and land in the hospital and helping them recognize them and avoid that. And it involves lifestyle coaching to get them to do the right things, like quitting smoking and losing some weight. And I hope the video will work here, but I want to show you an example of a program we've been running in partnership with the LINS for almost a decade now, and the results of that.
Hello, Anna.
Hi, Ulla. How are you?
I'm fine. How are you?
I'm good.
I just got Otto's numbers and I want to ask you a few questions. Do you have time for me?
That's fine. Yeah. You just shoot.
Okay.
You haven't had any changes with your medication?
As a matter of fact, she took Otto off some of the water pills, and it seems good. His legs are perfect.
The Telehomecare Program is about 6 months for the patient and myself as the provider. We provide them with 3 pieces of equipment: a scale, a blood pressure monitor, and an O2 saturation monitor that's connected to a tablet so that their numbers, when they're entering it in, it automatically gets transmitted to our clinic here at the hospital. And it's specific to either congestive heart failure or chronic obstructive pulmonary disease. With the Telehomecare Program, it's mostly health education. The health coaching is more like review the signs and symptoms, how they feel and what they're seeing. Ulla is the one doing all the observing and answering or responding on the tablet. And then also with the nutrition, diet, and activities.
We've been married for 66 years. We met actually because Otto had a little band. I was dancing. He was making eyes to me.
After we got married, we decided we were going to take a trip to Canada.
The opportunity was there, and we were young and could go out and see the world.
Otto is 90 and Ulla is 85. They had some exposure with technology, but this is actually the first time they've ever had anything like this at their home. Ulla is the primary caregiver for Otto, and you could see that they've done really well actually with this program.
When we get up,
Ulla say, Otto, there's a scale on the weight. Before I get any breakfast and nothing.
Yeah, I tell him to go on the scale. Let's see what goes on there. Then the blood pressure, and then the oxygen. And I answer all those questions. You took all your medication?
Yep.
Yeah. Okay, that sounds good. And your weight has been perfect today?
Yep. And now we can have breakfast.
At the end of the program there.
Ulla said, you can put the coffee on now. And have to do exercise every day.
Yes, you have to do some exercise.
And if you can go for a walk outside, then...
We have the community center, we can go down there and we can just walk around and stuff.
And you like the shopping center better.
Yeah, so we can also go to the shopping center and then we run around down there. And once a week, Anna reported to our doctor. Anna was a great help. She was really...
That's the best thing that ever happened, so you don't have to go to the doctor and sit and wait and wait and wait.
Yeah.
Our program has demonstrated a decrease of 57% for emergency visit, as well as a 54% decrease in hospital admission so far since we started in November 2013.
It's changed mostly for Otto, but I learned a lot. It's a great help because you're in touch with somebody every day. The program gives me great peace of mind. Yes, it does too.
Especially, we need that now if after 65, 66 wonderful years.
Get more information if you or someone you know could benefit from Telehomecare.
So, yeah, Matt will get it. So you can't really hire actors like that. That's real people. I want to show you the results of this program. There it is. Thanks, Matt. So we've had 3 LHINs that gave us numbers last year, Central West, Toronto Central, and Central. There's about a 60 to 80% reduction in hospitalization for these patients. Think about that, 60 to 80%. And by the way, chronic obstructive pulmonary disease and congestive heart failure, which are the 2 diseases that we're coaching for right now, are 2 of the 3 biggest reasons to be in a hospital. So if you took the elevator down here a couple floors and you walked around, most of the people in this hospital have lung disease or heart disease. 60 to 80% reduction in the hospitalization of these patients, right? There's no drug that comes close to that. And that's really about coaching them, supporting them, helping them understand the triggers that land them back in the hospital. The other thing you saw there was satisfaction. You know, I've never seen numbers like that, 97%. Where do you see that? So these people love it. They feel like this is the first time someone's actually cared about them. First time they've been cared for. Everybody's got a different reason because we all have our preferences. For Otto, this was all about sitting in waiting rooms, going to the hospital, wasting all his time going back and forth. Others have other reasons, like they want to play with their grandkids. They want the energy to do that. So it's all about the person. It's about motivating them. It's about helping them achieve their goals. When you think about it, you know, we have coaches that coach you, you know, to do things like shot put. You know, all you have to do is go like that. And there's a guy working with you every single day to make you do that better. These people are living with incredibly complex conditions, and we barely help them. They see the doctor once a month. They see a dietitian who tells them to do exercise and lose weight and whatever. How do we give them some support? And so I think this is an example of what we need to do as a health system, because this is the problem we have right now. I love this quote. It says, "The blockbuster drug of the 21st century is an engaged patient." And I truly believe this. This is really what's going to make a difference, and I'm going to give you some more examples. So, you know, we've been pursuing this now at OTN for a number of years, looking for the next thing we should do. We've developed something called our innovation process to test out more of these and see what works and what doesn't through a formal evaluation framework. We work with Weave. I think I saw Satya hide in the back over there. There he is. We look for things that work and things that don't. So the first graduate of that process was this, a mental health community. This is called Big White Wall. And the idea here is a peer-supported, anonymous site where people can come and share their feelings. There are mental health workers who are curating this. People can take courses online. They can track their mood. For people that are attracted to this kind of thing, it's a very awesome place. This was now funded as part of the province's mental health funding envelope, and it is now available province-wide. Consumers can enroll directly. You can go to our website. As you know, about 1 in 5 people in Ontario suffer from mental health issues. I think it's that side of the audience and me. So you or any family member can go right online, go to otn.ca/bigwhitewall. You can sign up, give it a try. Very powerful for those who it's right for. So that was our first one. This is the self-enrollment pages. We're trying other stuff. Home dialysis, $30,000 cheaper to go have dialysis at home instead of a hospital. People just need some support to do that. We've got palliative care programs happening in Champlain and Erie St. Clair, post-acute in North Simcoe, Muskoka. We've got surgical transition tools that hospitals can use to follow you up at home. And the big tough one is diabetes. And I want to drill down a little bit on that as an example of the big one. Because I think this is an enormous challenge for us and an enormous opportunity. So I don't know if you're aware of this, but in Ontario, there are 1.5 million type 2 diabetics, right? That's maturity onset diabetes. That's 10% of the population. There are another over 2 million people who are pre-diabetes, right? People who are going to get diabetes unless they make some changes. And that cost us $6 billion a year. What's our healthcare system spend right now? $50 billion, right? So this is 12% of our healthcare bill. And it's awful. Diabetes is the major cause of heart disease, heart attacks, heart death. It causes stroke. It causes blindness. It's the number one cause of blindness. It causes renal failure, and it causes amputations. And in fact, look at this shocking number. Did you know this? There's a limb amputation every 4 hours in Ontario, on average. Every 4 hours. Think about that one. And that's predominantly from wounds due to diabetes that do not heal. Now, diabetes is multifactorial. There is obviously a genetic predisposition to it. But the major causes are really around lifestyle, inactivity, smoking, poor diet, and the number one cause, of course, is obesity. That's by far the largest cause. And if you look at the numbers, that's another shocking number. 20% of us are obese. 20% of our population is obese now. It's a global epidemic. We're not the worst in the world. Go down to the southeast U.S., I think you'll find one of the worst in the world. But obesity itself has been linked to many, many issues. In addition to diabetes, there's more here. Lately, they've found it to be a major cause of cancer. Somewhere like 14, 15, I think, 15% of colorectal cancers, for example, are linked to obesity. So here's the punchline, right? There's been a study just recently, and there's lots of studies that are kind of confirming this. This is in The Lancet in February, where they took 300 diabetics and they split them up into control, usual treatment, and intensive weight loss. People who've had diabetes for 6 years or less. And the miraculous discovery was that 46% of the intensive weight loss people had a complete remission of their diabetes, right? Complete remission. They were no longer diabetics when they lost the weight. So just think about what that means. We have 1.5 million people. If we could get anywhere close to 50% or even 20%, that is an incredible, effort against the destruction that diabetes costs to people's lives and to our healthcare system. Imagine if we could knock 2 or 3 billion out of our healthcare costs just by coaching people to lose weight. So then the obvious question is, how do we do that? It's hard to coach, how do you get 1.5 million people to lose weight? I'll tell you, it's not going to happen when they visit the dietitian once and they get a sheet of paper that tells them how to eat, right? They need to be motivated and coached. And there's lots of technology. Oh, by the way, sorry, before I get there, I just want to tell you that the punchline, right, for this is that we think that things like diabetes are genetic. I want you to know that DNA is not your destiny, but dinner is. Okay? So now that we know dinner is, how do we do it? So this is, I think, what we need to do, right? We need to use a combination of motivation, coaching, support, digital tracking tools, teaching patients insights, and I believe that we can make a huge dent in this area. We just have to figure out how to do this as a healthcare system. Right now, we don't have any way to pay for it, for example. How do we even start to pay providers or organizations to do this? We don't have any way to motivate them. I'd like to see diabetes education centers in Ontario become diabetes motivation centers, where they're actually accountable for reversing the diabetes, doing the weight loss, bringing down the HbA1c. And these tools are doing it today. okay, and they're effective. There's lots of examples. There's lots of research. We have to bring this into Ontario. So I think those are the opportunities, and I guess my punchline for disruptive theme number 2 is really that we have to shift from our fragmented episodic care to behavioral, coaching, empowering care supported by digital technology. I firmly believe that. I hope I've infected you a little bit with that. Okay, so number 3, I'm going to stretch. This to me is kind of a profound thing because we all want this patient-centered system. I don't believe we have gotten there yet. We're all trying hard. But really, what does that mean? So I'd like to start here, okay? So this is kind of a very technical diagram of what I think today's health system is, right? So we put the patient in the center, don't we? Patient's right in the center there. But the patient is getting care one at a time from all of these different locations. Hopefully, if they've got a great primary care doc, somebody like Danielle Martin who wants to look after them, make sure they get great care. But the reality is communicating with the hospital, with the specialists, with the pharmacy, there is not a unified support for most patients. You may see 3 specialists. Do they ever talk to each other about you? No. They might send letters back and forth to the primary care doc. Patients come home from hospitals. They have 3 different prescriptions. They don't know what drugs to take. It's a very fragmented system right now. These are the challenges. There's multiple disconnected interactions with the health system. There's many providers who don't talk to each other. They're confused about their meds. They spend hours and days going back and forth to appointments and sitting in waiting rooms. They don't know what to do when something goes wrong. Who do you call when there's an exacerbation? Do you go to Emerge? Which of the specialists do you call? Is it your primary care doc? It's great for single acute consumer needs, right? We have really amazing hospitals and doctors and other health professionals. We have the world's finest as far as I can see. And when you're in their office, they provide amazing services. When you go home, you're not their job, right? Nobody is accountable for you as a patient, for your outcome, for your experience, for the total cost of your care, right? That's the gap that we have right now in our healthcare system. So I think there is an answer, and it requires a little bit of rethinking. I think we need to design models of care delivery that do accomplish patient-centered care. I stole this slide from somebody else, but I thought it was a great idea, which is called reversing the strategy arrow, right? So what we do today is we start on the left there. We have a bunch of stuff, places. We've got hospitals, we've got offices, maybe walk-in clinics, we have online, home, whatever. So we have a bunch of stuff. And when there's a patient problem, then we figure out, so what are we delivering? And that's box number 2, right? What are we actually delivering? Procedures, emergency care. Then we figure out, who do we serve? So who's paying us? And for the most part, it's going to be the government paying providers through fee-for-service or other contracts, or you belong to an organization that pays you. And then you get reimbursed, and hopefully you actually deliver that package of services to the patient. Okay, the problem is it's a package of services based on what you have. So it's what you have, and you're figuring out how to deliver that combo to your patients. Well, think about it the other way, which is actually, why don't you start with what the patient actually needs? Why don't you think about what they want and how how you can deliver the best possible service to them? And then you figure out what the business model is. So who do you actually have to pay to achieve that great model? And then you bundle those services appropriately, and then you pick the combination of people, places, and things that can deliver that, right? We never do this, okay? This is backwards, but think about it. We're taking a bunch of stuff, and we're mixing the cards around to try to deliver that to the patient versus thinking about what these groups of patients actually need. Now, it's not even individual patients. We can take large groups of patients. We can do what the marketers do. We can segment them. There's people that are walking well with a number of chronic diseases. There's people who are perfectly healthy who just need better access to their providers. So there are ways to segment populations and create these value models for them. I don't think, I think it's just kind of rational when you think about how to organize a healthcare system. So here's my definition of what patient-centered care should look like. So this is where we are right now. and this is the fancy automation here. What we want to do is somehow have these providers working on the same page around the patient, right? With accountability for that patient's total care, right? Somehow we want them to be totally accountable. And for the patient, what we want is something dead simple. I just want to go, and I don't want to have to deal with 50 different doctors and 100 different prescriptions. I want one page where I know my care is organized, I know what to do, I know what my plan is, I can look at my records. I just want to go to one place. That little TV is stolen from the Jetsons. Anybody see the Jetsons? Yeah. Elroy would have watched that. But it's not even meant to be technology. However, I can't imagine how we can do this without virtual care. Right? We need teams to collaborate. We need to have coaching and digital tools to support patients. We'd like them to see their record and share that with family members. I think we definitely need virtual healthcare technology at least to get these teams to work together and for the patient and their family at their end. So that's the glue that I think will hold all this together. Now, there's only one problem with this great idea. Is that it's really hard to do, particularly in our system. So I could only think of two ways that we could actually make this happen, okay? Maybe you can think of more. But here's kind of way one. And way one is to make an organization or a grouping more or less accountable for patient outcome, experience, and cost. And the example I want to give here is the U.S. healthcare system, which we mostly malign for whatever reason, but there's a lot of creative energy there. And what's happening down there is that, employers, for example, are paying for healthcare, and they're demanding better value. They're demanding better services, better patient experience, lower cost. And so there's a competitive environment there that is driving folks to figure out ways to compete. And there's some really interesting things happening. So, here's number one. Optum, which is a giant insurance company down there, bought DaVita, which is a giant health service provision group, providers actually. So imagine the insurance company bought all the doctors, okay, and put it into one company with total accountability for care. Guess what? Amazon, Berkshire, and Chase, these three companies have now banded together to start a new healthcare company to provide better, faster, cheaper experiences for their employees. Here's a very interesting one. CVS, it's a pharmacy partnering up with an insurance company. So imagine that. You go to the pharmacy to get your care. Total package of care, total accountability for cost and outcomes. And finally, what I think is the harbinger of the future. This deal is not done yet as far as I know, but Walmart and Humana are merging. One of the biggest insurance groups in the world, the biggest retailer in the world. Walmart is the biggest retailer. What does Walmart know how to do? They know about customer service. They know how to lower cost. Imagine if they get this right and they can deliver care to you as a package deal at all of their stores. It's an amazing opportunity for real customer-focused care. Now, we have a bit of a problem in Ontario because we can't really buy OHIP. Maybe somebody will put it up for sale. I don't know. Depends on who wins the election. But I think that there are efforts. There's a lot of efforts. I don't want people to leave here thinking we're not doing a lot in Ontario, because we are. There's the Northern and Rural Hubs idea kind of approaches this. Our bundled payment models, our QPIs, QB, whatever they are, that approach, QBPs approach that as well. And of course, our LHINs are there to do this, right? And they are making progress. We've seen a lot of changes, but they still have a long way to go. And in particular, engaging the physicians and health providers is still going to be a big challenge because they still are not funded through the same pot. So we're kind of inching in that direction. But I would propose solution number 2 here, which is that we lead from behind, okay? And we lead from behind with virtual healthcare. So you remember the Elroy Jetson, scene there? Can we create those models of care across the community? So in other words, can we, sit down, look at a patient group, let's look at the people with heart failure, let's look at the people with diabetes, let's look at, aging, frail populations, and let's design what they really need. Let's figure out if in their perfect world, what does it look like for them to have simple, easy to access healthcare? Then we have to figure out, and this is the trick, we have to figure out how to create value for the providers to actually participate in that, right? Because they got to get paid. So we have to figure out their role and what they do, and then we have to get their commitment to be part of that process. The cool part is when you use technology, you actually know what everyone's doing. So if somebody makes a commitment, you can see if they're living up to their commitment. If we give patients a service level agreement or whatever it is we have to do, we'll know if that's met. And that's not exactly accountability, but it's transparency. We can out people. People have don't want to be shamed in public. And I think what we want to do is build that towards accountability while we're figuring out how to restructure the rest of our healthcare system. Just by coincidence, this is exactly what we're trying to do at OTN, right? So we're trying to find those models of care. We're trying to figure out what the value is and how to get people to participate. We look for somebody who might want to fund it. In the case of our Telehomecare program, the LHINs have stepped in and said, yeah, you know what? Keeping people out of the hospital is probably a really good idea. We'll fund this. We think that there's going to be a business case in the future for it. So, every time we do this, we have to find some way to make it sustainable, and that's the challenge, right? We don't have those competitive drivers the way we do in other places. So that's kind of my idea, and that's kind of what we're doing. And I hope that you can do it too. And what I think we need to ask ourselves is, what kind of access do you want? Do you want to sit in the office? Do you want to sit in the emerge? What are you going to demand out there? What resources will you need to empower self-management if you're in a place of developing health services? Are you getting service-centric care, right? Episodic service-centric care, or are you really getting patient-centric care? That's a question you should be asking yourself. I'm driven by the gap between what our healthcare system is right now and what it could be, right? And what it could be, particularly with virtual healthcare. I think we have incredible opportunity. So I'm hoping that wherever you sit in the healthcare system, you can ask these questions, right? Stimulate a little activity. Maybe get mad, okay? And do something, right? Because I think it's time to do something. We have all the tools at our fingertips. I think this is an incredible opportunity for us to make a huge difference in the care in our future and to make our healthcare system sustainable. So thank you for listening to my rant.
So we do have a few minutes for questions. So if you have a question, raise your hand and I will bring the mic to you.
Thank you very much for your thoughts. I'd like to ask a question that's non-technology related. It's called funding. We currently deal in a world that's predominantly fee-for-service or universal budget, which is reason for everyone wanting to see increases. How does technology break through to change how funding is done? Because we're going to be living in a healthcare world of currently we're living in 3, 5, 4% type of increases unless there's, so technology has a tendency to fit in the pilot versus the implementation.
Yeah, you've described the central challenge in my life, so thank you for that. Because, I think when you look at what we did in the early days with technology, basically it was easy because we had a patient and a provider, right? And we wanted to link them up by video visit. And that was pretty much the same system as we've always had. Imagine, if you're a doctor, the patient could be sitting in your office, or you could put a frame around them and they're on a screen. So we ended up being able to convince our wise government at the time that they should fund that, just like they would fund a visit in the office. Where it gets a lot harder is these new models of care, because there's no existing funding envelopes to do that. And so we have to go out and try to find them basically right now, and that's where the blood on the wall is, because it's hard. If there's no funding there, it's a big deal to try to bring funding in, to try to develop value for all the people who have to participate. And so we end up being in a frustrating place where, for example, the Telehomecare program, it obviously saves money for the system, right? Because if you avoid, we avoided over 3,000 hospitalizations last year. The payback was probably about 5 to 1 for every dollar invested. But nobody can take that money out and do something else with it because we haven't structured the payment like that, right? So we end up with these sort of frustrating, obviously great solutions without a model. So I think what we're trying to do is inch by inch, develop these models, get these things going. Hopefully, while policy is being developed, while we prove out the cases, policy is a slow ship, but policy does develop, it does change, and we're hoping it'll catch up to the modern age. Right? I don't know if that answers your question, but yeah.
Thanks very much for the great presentation. My question is about looking into the future, and when you've addressed all the barriers and we fast forward, what would your prediction be in terms of the reduction in ED visits and admissions?
Yeah, great question. So the first thing is, this is not a sideshow to healthcare, okay? This is going to be healthcare. Believe it or not, this is how it's going to be delivered. I don't know when. Like I said, 10 years ago, I said it would take 5 years, so I'm wrong. But this is how it's going to happen because this is what we need and want and what we're used to, right? We all have smartphones. This is your telemedicine device. Tell me what you do right now, in healthcare on this device. So what was your question again? Numbers. Okay, sure. Yeah, so the studies I've seen, it can be dramatic. I saw one study that I think it said 80% reduction in ED in some places, but I think it's closer to 20%. But you have to look at when you increase access to the public on demand, you also have to think about maybe it's going to increase. And our government, of course, is very worried about people creating puppy mills where they just see lots and lots of patients. That hasn't happened in other places. There normally is some utilization increase, but it's matched by some decrease of other services. But on balance, increasing access is always going to be good. I think the big savings are going to be chronic disease management, right? I think if we can avoid those diabetics, I literally think we can knock a couple billion out of our budget if we did that properly. I think that for congestive heart failure and CHF, we've calculated that if we got all the patients in there, we would save probably $800 million a year overall in hospitalization, ICU costs, and other costs. We've created a kind of a giant table that has the savings from each of these things. So you saw $5 million a year from corrections. The virtual ICU programs in Northern Ontario are knocking a couple million off transportation costs every year. You saw our Northern Health Travel grants, at least $50 million or $40 to $50 to $60 million avoided a year. So when you start to add all that up, I don't think it's out of the realm to save at least 10%, maybe 20%. We won't save it though. What we'll do is we'll reduce the pressure for future years, right? We'll knock that curve, instead of going like this, it'll kind of flatten out, and it'll be better for patients. That's the punchline.
Any more questions? With that then, thank you very much, Ed Brown.
Thank you.
That is it. Again, I mentioned for the summer, so we will be taking July and August off. I have started confirming speakers for the next series. I do have Brian O'Rourke, the President and CEO from Cadith, coming next year. As well, Kevin Smith has been confirmed, and so we're starting our planning and looking forward to our next series. Other than that, have a great summer.